And thanks everybody for coming along. I'd like to start by acknowledging the traditional owners of the land on which we meet, and in particular, the Bidjigal people who are the traditional owners of this land where we're meeting in the room, and pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islanders who are joining us today, and then acknowledge that the lands are unceded. So, as I said, this is the 13th Brett Tindall Memorial Lecture. When we started this, we had an emphasis on bringing in senior speakers, but Brett Tindall died aged 33 in 1994. So he was at that stage an early or mid-career researcher who'd achieved an immense amount. And so over the last couple of years, what we've decided is to change the focus to celebrate up-and-coming early and mid-career researchers who have achieved outstanding things. And so that's the focus of the Brett Tindall Lecture going forward. So as I said, Brett died aged 33. He had originally trained at Cumberland College in a health science degree, and then had subsequently enrolled as a mature age student in medicine in Newcastle. However, while he was enrolled as a medical student, he discovered he was HIV positive, and decided to dedicate his life to attacking this disease through research, and was one of the early employees appointed by David Cooper at the National Centre for HIV Epidemiology and Clinical Research. Brett was appointed there and rapidly rose through the ranks, holding various research positions, but also was appointed as centre manager. So was clearly multi-talented. Brett conducted outstanding research. The two most profound papers that he produced during his time at the National Centre was one on the seroconversion illness, or the primary infection illness. So this was the first description of this, both putting together the symptoms and the laboratory markers of seroconversion. It was a landmark paper published in The Lancet, a real bringing together of astute clinical observations, carefully collected with sophisticated laboratory techniques, with links into the community and into primary practice. That paper made a splash, but ironically, what the whole primary infection illness wasn't really truly recognised until about 10 years later, when David Ho rediscovered it in the United States. Brett also, his other great claim to fame was that he helped identify the what became known as the Sydney Blood Bank cohort, which was a group of people that weren't progressing with HIV, who had been infected through blood transfusions before screening had been standardized. All those people had been infected by one donor, but neither the donor nor those infected were progressing. And he managed to, with the Red Cross, identify this cohort, and subsequently it was then understood that the virus those people were infected with was an attenuated virus. It had a deletion in the NEF gene. And that actually then spawned a whole suite of worldwide research about attenuated viruses, how they behave, and whether they could be used as vaccine candidates. It also spawned the long-term non-progressor cohort, which many of us in this room have worked on, which continued right through to 2015, and for which we still have samples in the laboratory. But Brett's academic outputs were really based on his advocacy for patients and for the community. And he was an early member of the AIDS Council of New South Wales. And through that position and through his position at the National Centre, he was identified as someone who really had a great understanding of how the epidemic was evolving in Australia and the public health response, and was recruited by Jonathan Mann to various WHO committees. And it was through those committees that he met Michael Kirby, and Brett and Michael became great friends from that time through to Brett's death. We celebrate Brett's career not just because of his academic achievements, but because of the way he taught us how to do research. That approach of bringing together the laboratory, the clinic, and the community together to make really landmark, globally important observations. And so we would do well to remember Brett as we design our research projects going forward, and never forget the lessons that he taught us. And so today's lecture, which is the 13th Memorial Lecture, will be presented by Louise Causer. And the work that Louise is going to present results from great experience that Louise gained through her training both here and at the London School, and is a great example of the sort of work that can be done where you bring sophisticated molecular techniques together with clinical acumen and public health intent, working with communities. And so Louise is going to tell us about work she's been doing in Aboriginal communities around STI testing, and how that drives transformative results in terms of treatment and outcomes from those infections. And so with no further ado, I'm going to hand over to Louise.
Thanks very much, Tony, and thanks everybody for coming along today. I'm feeling quite nervous, but I'm really excited to be able to present some work that I hope honours the memory of Brett Tindall. It's certainly, I think, an example of a research journey that has some incredibly important attributes around collaboration and community engagement that essentially has underpinned, I think, what you'll see has been a very successful translation of initial early research into sort of program and community impact. So before I start, I'd like to acknowledge and pay my respects to the Bidjigal people, the traditional custodians of the lands on which we're meeting today. I'd like to extend that respect to custodians of all the lands on which we're living and working, to their elders past, present and future, and to all Aboriginal and Torres Strait Islander colleagues here in the room and online today. So I'm going to tell you a bit of a story. It's going to go back to probably the initial phases of when I first started my PhD here at the Kirby, which is a little bit more than 10 years ago. And I'll talk, set the scene with a little bit about how the idea came to fruition, and talk a bit about the early work, which involved some lab-based tests, evaluations and field evaluation, and the first randomised control trial of a point of care test in remote communities. And then I'll talk through the translation of those findings over the past 7 or 8 years, and then do a reflection on some of the evaluation of that program that has led to some really important policy and funding changes in the last sort of 12 months, which we're looking forward to seeing implemented. So this wouldn't be new to most people, but I'll just set the scene about primary care in remote Australia. Primary care is generally delivered by Aboriginal community-controlled health organisations and some government-managed health services. And these are essentially culturally responsive and safe care places that deliver acute, chronic and antenatal care services. They're largely staffed by fly-in and fly-out nurses and doctors, but have a core community of Aboriginal health workers and practitioners who also provide care. There are intermittent specialist visits, which are usually fly-in, fly-out, and these services are generally characterised by quite high staff turnover in the sector. In remote, as you'd imagine, there are also other challenges, including environmental and socioeconomic challenges. And just to note that there are significant distances from these remote primary care services to laboratories and other services, which are more accessible in many settings to urban and those that live less remotely. So sexually transmissible infections in remote Australia are somewhat unique. The control of these infections is generally based upon a test, treat and trace strategy. Syndromic management is widely used in remote communities for symptomatic presentations, but asymptomatic screening is recommended and is usually done following a lab-based test and treatment based on the result of that lab test. Knowing that context that I just briefly described, there are frequent delays in the diagnosis, treatment, and there's often a fair amount of loss to follow-up, largely because of significant distances to laboratories that can be thousands of kilometres away. And often there's difficulty recalling clients for treatment, partly because the population is often quite mobile, but also because of limited staff capacity to follow those clients up. There are also delays in then contact tracing and partner management as a result of those delays in diagnosis. So all of these elements, along with the legacy of colonialisation and other attributes, have contributed to higher rates of STIs and their adverse sequelae in remote communities, including reproductive and poor pregnancy outcomes, such as pelvic inflammatory disease, infertility and ectopic pregnancy, and preterm and low birth weight babies. So in this context, health services were seeking a faster way to diagnose and treat STIs, to reduce the amount of time spent by staff to follow up and treat, to offer treatment based on the pathogen causing the infection at the same time as an initial consultation, and to potentially improve and commence partner notification and management. So in that context, the idea of whether a point of care test might be used to address these challenges was raised. And that set off a whole train of different other questions. So what types of tests might be available in Australia? How do we choose which one? What would work best? How will it be used? And will it be used? And I'd just like to draw your attention to a framework that is somewhat helpful in being able to consider a point of care test in this setting. And just to note that what first comes to mind often is, well, is the test accurate? Can we afford the test? And is it acceptable? But there are a whole other range of elements that are important to consider in the first instance. So this assured criteria was a framework that was proposed some time ago. I think it was about 12 or 13 years ago, and it's been updated to have a couple of other attributes of importance. But essentially, this is just the first layer of attributes to be thinking about when considering a point of care test for use in this type of setting. The other piece of the other framework that I find quite useful in thinking about the pathway to generating evidence that would support the implementation and use of a point of care test in a particular setting is this framework that was that appears in a paper by Rosanna Peeling. And just to draw your attention to the outlined red area here, this is essentially the journey that I'm going to take you on today. The technologies that we were considering were those that were already available, so we weren't involved in the development of those, but we were very interested to know, how they would be used in our setting. Would they be accurate? Would they be acceptable? And so I'll just walk through these different elements and demonstrate with our research how we've achieved this pathway and generated the evidence to implementation. So casting our minds back more than a decade, what tests might have been available at the time for consideration? Well, there were what are considered traditional lateral flow rapid tests. These are antigen detection tests, relatively inexpensive, pretty rapid. However, they've generally had fairly poor sensitivity and specificity. They also detect only one, at the time, detect one antigen at a time. On the market that was becoming available was a new molecular-based point-of-care technology. This was the same technology that had been used in resource-limited settings for TB, and a new dual detection assay for chlamydia and gonorrhea became available. So it was essentially using polymerase chain reaction technology, the same as was being used in reference labs for diagnosis in Australia, was reported to be highly accurate in studies that were conducted overseas and in the lab. However, orders of magnitude more expensive and a relatively longer time to result of 90 minutes. So this is what was on the table, and we then designed some studies to understand what would be the most appropriate test, and then to see how it might be used by in the local setting. As part of the evidence that was generated, an Australian laboratory evaluation was done by colleagues led by Sir Pierre Tabrisi at Melbourne University and at the Royal Women's, which essentially confirmed that the assay itself, the chlamydia and gonorrhea assay, was analytically highly sensitive and specific. I won't talk about the details there, but just to note that that was an Australian study that was done that led the first steps towards what we next did, which was a field evaluation. So the next thing to understand was whether these types of tests might be feasible, what was their ease of use, and what did their early performance look like in the setting in which we were considering using these. So a field evaluation was designed and conducted at 2 remote Aboriginal community-controlled health organisations in Western Australia. And this was done during an annual community screen, where they screen lots of the community, doing asymptomatic screening and using predominantly urine specimens for testing. The field evaluation looked at evaluating 2 of the available lateral flow tests, one for chlamydia and one for gonorrhea, and the new molecular-based point-of-care test, which was the Gene Expert chlamydia gono assay on a 4-module platform. So you can see there's a couple of photos there of the field trial, and you can see that the setup and the footprint of the different point-of-care tests is quite different. The ease of use and the specimen preparation was quite different, and the time to result was quite different. But what was most striking was the performance, and here's a table from the paper that really demonstrates the superior performance of sensitivity and specificity of the Gene Expert. So from almost 100 specimens, 200 specimens, both the sensitivity and specificity for chlamydia and gonorrhea were almost 100% for the Gene Expert, whilst for the 2 lateral flow tests, it was significantly lower. Certainly the specificity was not in a range that would be, the sensitivity rather, was not in a range that would be suitable for use in these settings. So having determined that the gene expert molecular test would be potentially suitable for use, we embarked upon a randomized controlled trial using the point of care test, which was the molecular test, in the hands of the end users who were clinical staff at the service. So this was a crossover cluster randomized control trial. It was conducted at 12 remote Aboriginal primary health services. Point of care testing was actually integrated into their primary care workflow, and it was performed by trained clinical staff. This included Aboriginal health workers and practitioners and nurses. And this really represented the first use globally of this molecular point of care test in primary care by non-laboratory staff. The main outcomes to be evaluated were to look at the operational performance, the clinical effectiveness, and also to evaluate the acceptability of this technology to providers and clients. So what did we find? We found that the point of care test was highly concordant with the laboratory reference tests. The table on the right is an excerpt from the paper that was published, just showing that among almost 2,500 tests that were done, the concordance was incredibly high. And that makes sense. It's using the same technology as in the lab. The few discordants that were identified were actually investigated in quite a lot of detail, and the sort of outcome of that was that these discordant results were really at the limit of detection of this technology, which kind of translates into these are infections with low organism load, and to be expected. It didn't matter which test you used, you'd end up with slightly different results. The other big piece of information, obviously, was what was the clinical effectiveness in this setting. And the findings just briefly indicated that among those that were positive for chlamydia or gonorrhea, there was a reduced median time to treatment in the community by 7 days. And there was also an increased proportion of those treated within 2 and 7 days. So for those who were treated, who were positive and by lab and treated, there were 30% of people who were diagnosed by lab were treated in the first 2 days, and that compared to 60% when diagnosed by point of care. There was also increased treatment uptake at 4 months. And these categories of time period are important because the sequelae of infection, such as PID, can develop relatively quickly. And so an improvement at those earlier time intervals, even if it's not the same day, makes a big difference. So just jumping to the other component of the randomized controlled trial, there was some acceptability work done with providers and clients. Semi-quantitative surveys that were done demonstrated a very high degree of satisfaction with the use of the point of care technology, and in-depth interviews that were conducted with trained operators highlighted the perceived benefits. And just to be able to summarise those, they made operators and the health service feel more empowered, it enabled, and that they could conduct their work more efficiently. Oh goodness, there's an unusual script at the bottom there. But essentially each one of these quotes were examples highlighting that empowering and enabling that was a result of having the technology available at the service. I mean, I do feel like a scientist at times. You know, that was obviously something that was very meaningful to a particular operator. And the fact that they could have people treated by the same afternoon was kind of phenomenal to their minds in that setting. So buoyed by that success of the randomized control trial and lots of enthusiasm from the services that were participating in the trial, and as a result of, I guess, funding that was successful, so an NHMRC partnership grant led by Professor Guy, Commonwealth funding, the WA and Queensland governments, Tango 2 was launched. And this was essentially a translational research program and an evaluation built in. Among the 12 sites that were part of the original trial, they were all offered the opportunity to continue almost all agreed. And then the point of care testing was scaled up to a target of 32 sites across 4 jurisdictions. Interestingly, in 2018, a trichomonas detection assay became available and TGA approved. So as part of this expansion, trichomonas testing was included in the program. This program, Tango 2, was a really strong, has been and still is a really strong partnership and collaboration with the Kirby Institute and Flinders University International Centre for Point of Care Testing, leading the implementation and operations, and also the evaluation, and collaborating very closely with the peak Aboriginal community controlled health organisations, government health services, pathology, other academic institutions and industry. Services were invited to participate, and they were essentially eligible for consideration if they were a primary care health service located in regional or remote or very remote Australia, serving a predominantly Aboriginal and Torres Strait Islander population, and seeing a large number of young people and with a relatively high burden of STIs in their community. One other component was, I guess, their willingness to participate in the evaluation component of this work, and also that there was sufficient staff capacity to be able to implement the point of care. As part of the program, all the equipment and consumables and the infrastructure is provided. So it relied on, existing staff, but all other components were provided by the program. One large piece of work that was really important to the implementation and scale up was this critical infrastructure. And it's often not well appreciated, perhaps when thinking about how to translate what looks like a good test into a real world use setting. So this, what we call affectionately the flower diagram, has been developed to kind of, I guess, highlight the various elements there around as petals. And I'll just touch on a couple of those that I thought were, I could speak about today. The governance aspect, I think that it has been really important, and just particularly like to highlight that we had a group of Aboriginal and Torres Strait Islander test operators who formed what we call the STI Point of Care Testing Leaders Group. And this group was established to ensure the cultural safety and implementation, the appropriateness of implementation in our resource going forward. So this group was integrally involved to the development of many of the aspects of our work and implementation, and that regular jurisdictional point of care test meetings have happened over the life of this program and included key stakeholders who have helped guide and operationalise and draw our attention to barriers and challenges, and working together, kind of finding solutions to ensure that the implementation and scale up could continue. As part of the program, a quality management program needed to be established and implemented and monitored, and this included external quality assurance and also quality control specimens that are conducted monthly at the sites. In addition, bespoke training was developed, and this, both the quality management and the training sort of fell under the responsibility of the Flinders University team, who also deliver other chronic disease point of care testing programs in remote Australia, so drawing upon their expertise in that field. Training was delivered originally face-to-face for everything, but also developed an online approach to cater to different scenarios in different settings. And there's a theory and practical competency assessment, and that competency is valid for a year. So as part of the integration, it was really important to make sure this testing approach worked in the services and needed to be integrated into their workflow. Some services integrated the device and the technology into their routine opportunistic screening, for example, like an adult health check. Some services that conducted an annual screen where the entire community, there's an attempt to test the entire community over a defined period of time and treat all that was positive. They found that that worked well for them. And then there are also examples of more outreach and mobile models, or where specimens were collected in outreach and brought back to a central location for testing. I haven't got time to go into all of those, but that's some really exciting ways that the health services chose to use the device. So they were given the opportunity to integrate the device in a way that suited their running of their clinic. We relied on existing clinical staff as trained operators, and I think I mentioned before, these were largely Aboriginal health workers and practitioners and nurses with some doctors. And to date, more than 750 staff have been trained to be able to run STI molecular point of care testing. Not all of those are currently competent, but I guess that just gives you an idea of the amount of training that's been undertaken over the last 7 or 8 years. And perhaps the other piece of work that was really critical to the integration and use in primary care was the development of a connectivity system that was specifically designed to support the integration in primary care. So there was nothing that was existing that would work with this new technology in primary care. And so some time has been spent developing and optimising this system so that it aligned with the way health services received their usual pathology results. So it's sort of seamless and easy and a permanent record in the patient electronic health record. Just to briefly mention this system, this has been published by Amit Saha and others, and this system took advantage of the digital output of this molecular point of care testing technology and essentially was designed to maximise the data quality, ensure the device performance and minimise the clinician workload. And this was something that clinicians up front during the acceptability research had sort of identified as being really important to make sure this was well integrated. So as a result, a bespoke system was developed to allow for the rapid, complete, secure delivery of results to end users. And those end users are primarily the clinic and the patient management system. So using those results for clinical management, to allow for mandatory notifications nationally for chlamydia and gonorrhea as notifiable diseases. So a result to the Departments of Health for counting at their end, and also for us as the program implementers to be able to monitor what's going on in the program, provide support, and just generally logistics and procurement and quality management. As I mentioned, that's been optimised over time, and probably the importance of that system and the reliability of that system has become ever more in our minds. We're at this stage, we're able to deliver results to all those end users. 90% can have a result within 2 hours. The result itself is immediately available on the laptop, but it's in terms of getting elsewhere. And most results are available by the same day, which in a remote setting is pretty impressive. And the completeness of the demographic data that we're able to retrieve is very high as well, which is also sort of an additional attribute of importance. So moving on, so Tango 2 was going well. We were able to secure additional funding from the Commonwealth Government. Everybody was really enthusiastic. And so we were able to seamlessly move into what we call Tango 3, which was the 2020 to 2024 period. Continued operational implementation and scale up. You'll remember that there was COVID at this time. I'm not even going to really talk about that at all. It's a whole lecture in itself. But essentially, using the existing network that we had through STIs, we were able to the team, and with a bit of upskilling for us all, able to rapidly pivot and be able to operationally deliver and support health services to be able to conduct COVID testing. When the assay became available with additional flu A, flu B and RSV, we've switched to that. And so now services are able to offer molecular testing for 7 infections at most services. As of this year, we've got we used to have separate contracts with the Commonwealth. It's now a fully integrated program, and we're now known as the First Nations Molecular Point of Care Testing Program. So this is just a little review of what I've just talked about. Started with Tango, Tango 2, Tango 3, a little blip there with COVID, but actually, everything kind of worked in our favour, and we're now at the First Nations Molecular Point of Care Testing Program. The chart actually shows the scale up of health services over that time. So, it's slow and steady, and certain jurisdictions are more well represented than others, and it sort of speaks to the remoteness and where the stakeholders felt the benefit would be. This is, I guess, a nice map to just show you where the devices are located, and also to note that most of the locations are able to do both respiratory and STI point of care testing. And I think this is the most recent information for STI point of care testing. We've got 77 clinics across 6 jurisdictions. Over the time of the life of the program, more than 60,000 STI patient tests have been conducted. And during that time, more than almost 9,000 STIs have been detected and cured more quickly. I just wanted to take a brief interlude here to acknowledge, I guess, this integrated program, and delighted to share some artwork called Walking Together for Infectious Diseases. The artist is an artist in residence, Mel Fernando, who's part of our team, and she designed this and created this beautiful artwork that we're using going forward as our logo. And I guess the story is really beautiful. It's there, it's too much to read just now, but perhaps just to read the last paragraph, which really, I think, exemplifies the journey. The vision of this artwork represents walking together for a common need, which is preventing infectious diseases, walking hand in hand with community members, health services, clinicians and researchers, learning, sharing, having open communication, building rapport with each other, and changing the way that point of care testing is done within communities for the benefit of eliminating infectious diseases. I mean, I think that says it all really about how far we've come and the way we approach implementation, but also the research. So maybe if I just briefly sort of switch gears for the last several minutes, is to talk about, I guess, the importance of evaluating the program that we've been operationalising and implementing. And I guess the importance of taking care and taking close attention to ensuring that the program that we've been scaling up is achieving the goals and the impacts that it was designed to do, and to identify gaps and challenges, and to generate evidence for policy change and sustainable funding. So I guess along this pathway, there'd always been a question from the health services and from our stakeholders, it's all very well, but how will we make sure this continues beyond the life of intermittent Commonwealth funding and, when your research is done? So we did, as part of the Tango 2 program, there was a component that was built in around doing a research. It was a little bit delayed because of COVID, so the results have only been published more recently. But if I just go through some of the key findings from that, I hope I can convince you that we've got the program goals and impacts have been achieved and are being achieved. Essentially, this research was done with using a light touch, using routinely collected data. Some clinic audits needed to be done to supplement where there were some gaps, but also the program testing data that we were able to collect as part of that connectivity system has informed and contributed. So first of all, looking at sustainability, we're lucky to be able to have 7 years worth of data to look back on, and we performed a trend analysis of mean monthly tests over time. And just to note that I guess April 2020 was when the national public health response to COVID was implemented, and there were lockdowns and restrictions on people's movements. But these two charts on the right show the trend analysis for, the top one is chlamydia and gono, and the one below is for trike. And remembering they were implemented at slightly different times because of the TGA approval of the trike test was a little bit later. But essentially for that first period from January 2016 to March 2020, before the lockdowns were implemented, there was a clear increasing trend in mean monthly tests. And then during and following the COVID epidemic for the subsequent 2 years, there was what was identified as a non-significant decrease, which, speaking to our stakeholders, they actually saw that as being quite a, they saw that as stable testing in the face of all the competing activities of COVID and trying to keep communities safe and doing point of care testing for COVID at this time. The fact that they were able to maintain their testing through that time was, they believed to be a significant achievement. So what was happening with, I guess, improved time to treatment and the clinical effectiveness in this programmatic setting, where basically we'd provided support, but health services were using the test in a way that suited them. So outside of a more controlled trial setting. This chart on the right sort of summarises the time to treatment by category along the x-axis and the proportion treated on the y. The blues represent chlamydia and gono, and the oranges represent the trichomonas. The light blue is lab, the dark blue is point of care, the lighter orange lab, and the darker orange, the TV point of care. And similar to the trial, you'll see that there were significant increases in the proportion treated in each time category following a point of care test compared to a lab test. So in summary, these findings mimicked what we saw in the randomized control trial, which was both reassuring but also quite powerful to think that this was being able to be done, and the improvements and benefits were also being achieved in this non-trial setting. We calculated the median time to treatment, which was reduced by 10 days by using a point of care test for chlamydia and gono, and by 25 days for trike, which is pretty incredible. And so we thought, well, we could potentially look at infectious days averted by applying these reductions in time to treatment to the 8,800 positive results in the past several years. And this translates to more than 118,000 infectious days averted over that period of time, which, if you think about onward transmission to partners, that means less time to transmit onwards, and also potentially less time to develop the sequelae that we'd spoken about previously. We also wanted to make sure that the quality of testing was being maintained, and I'll just really quickly go through this, but essentially across more than 4,000 tests for chlamydia and gonorrhea, we were able to show very high concordance with the laboratory test of the same specimens, and the same for trike. And one other indicator that's we've been monitoring and is important to probably note is that when you run a test, on occasion you'll get an invalid or an error, and we see an overall unsuccessful rate of about 2%. This takes into account that operators are trained and requested to do a repeat test, and that most of those repeat tests produce a valid result. Sometimes that's as a result of a device issue. Sometimes it's been a result of an operator issue. Where it's an operator issue, there's more training. If it's a device issue, we can do some maintenance or do what's necessary to replace the device. Recently, my PhD student and colleague, Annie Tangi, has done some further analysis to look at whether point of care testing might have influenced overall STI testing at these services. And she did some analysis using an interrupted time series approach assessing before and after the introduction of point of care testing. And not to get into too many of the details, but essentially in the before period, but at the time of transition from lab to with the introduction of point of care testing, there was a significant increase, immediate increase in mean monthly testing, which is not all accounted for by just the point of care test. So it suggests that the introduction of this technology has actually improved overall testing, and that this was sustained over the period of follow-up. There was also, and not presented here, a large immediate increase in the numbers of STIs detected as a result of that increased testing. This was presented at IUSD recently and hopefully will be ready to share more broadly early next year. And really to note that this is the first study that's demonstrated a sort of an potentially unintended impact of the STI point of care testing on uptake and infections detected. The all-important economic evaluation that was part of this Tango 2 work involved looking at the cost effectiveness of STI point of care testing compared to standard care. This was a modelled evaluation from a remote health service perspective, included a whole range of inputs, including uniquely the evidence from an Australian trial and program, and also other published literature specific to the Australian context, and also practice guidelines, expert opinion and interviews with staff. And just really briefly, I guess the take-home message was that STI point of care testing is cost-saving and more effective in this remote setting compared to standard of care. And much of that is largely driven by reductions in the costs associated with staff time to follow up and treat patients, and also the reductions in PID and low birth weight and preterm births, which incur quite a significant cost for management from these remote settings. There was also some additional acceptability work done, and this was led by Lee Lafferty, which I'm just going to really go through very quickly, not doing justice to this, but these were some terrific in-depth interviews that have shaped and guided our implementation over the last few years, and demonstrated that the acceptability of the technology was really influenced by operators' self-perceived competency, I guess, and how they perceived the additional burden on their resources in the health service. It identified formally, again, the barrier of high turnover of staff at services, and also noted that patient reach was definitely considered to be an enabler of STI testing scale-up. So I guess this is the pointy end. We submitted a Medical Services Advisory Committee application in November 22, using all of that evidence from the randomised control trial demonstrating the clinical effectiveness, the performance. A large component was the cost effectiveness analysis that was led by Carolyn Watts. There was information about the acceptability, and we also included the best observational data available as part of the modelling work. All of that was packaged up, and in addition to advocacy and support from our stakeholders who were along the journey with us, we had the MSAC approved or supported in February 24, so earlier this year. And that was announced in the federal budget this year. It's the first rebate for an infectious disease point of care test, and uniquely includes a cost recovery component for staff time. To be eligible, however, the service needs to be located in a remote and very remote setting. It needs to be an Aboriginal medical service and enrolled in the First Nations point of care testing program. They need to be able to demonstrate meeting the quality and training requirements of the program, and they also need to be conducting both the chlamydia, gono and trich tests to be able to claim the one rebate. This is ready to be available for claiming from the 1st of November. So we're right on the cusp. The other changes, I guess, that have happened along the way that have supported the sustainability and implementation have included changes in national and jurisdictional STI strategies. STI point of care testing is now included in clinical guidelines. There was a change in the case definition, national case definition for notifications for chlamydia and gonorrhea that includes now detection by point of care, not simply lab-based. And we've been successfully renewed by the Commonwealth for another 2 years to take this all forward through to the middle of 2026. So there are challenges, of course. I've given you the sort of rosy version, but just to note that you need to have, we need increased uptake of point of care testing to ensure that there is true equitable access across all the services and communities that would benefit. And really only about half of health services who might benefit from this have testing available at the moment. And at those services that are doing testing, only about 1 in 3 are actually offered a point of care test for a variety of reasons. So a lot of the work that we're doing now is about increasing that uptake and thinking about strategies and working with services about how to help and support that improved uptake. Some of the things that have been raised by stakeholders include integration, kind of solving workforce capacity, which is a little bit outside of our realm, but we've got some ideas there, and to ensure long-term sustainable funding. With specifically the STI point of care testing, I guess there's an interest around broadening the geographic scope of the rebate, and also being able to disaggregate the chlamydia and gono from the trich where it might be appropriate to do one but not the other in a particular setting. So the next steps are really focused on assessing alternative workforce models for point of care testing, which might include non-clinical staff as operators, also to advocate for expanded geographic criteria for the Medicare rebate. We're collecting additional evidence and looking at best ways to do that, and also to support health services to increase uptake through novel or new or supporting engagement strategies with community and providers. There is another piece of work that's really exciting that's using the infrastructure and the relationships that we've established over the time of the Tango program. And this is going to look at other priority infections using the same technology, Group A strep for prevention of rheumatic heart disease, and HPV testing for the prevention of cervical cancer. So that's it. And just to acknowledge that certainly this has been a long journey, and I've been very privileged to be part of it from the beginning and continuing, and that I'd just like to acknowledge all of my team members as well, who have been instrumental in supporting me and sharing, and we've been learning from each other. And I feel, very privileged to have been a part of the journey. So thank you very much.
So thanks, Louise. That was truly special, a real tour de force. So if there are questions, please come to the microphones or put the questions into the Q&A box if you're online. If I could start while people are thinking about their questions. So in terms of the limitations, is it machines not performing, or is it staff turnover, or is it just the capacity on the day? I mean, these are very accurate, but they're not high throughput tests. So which of those drive the limitations in the service, or is it a combination of those?
Thanks, Tony. It's quite complex. I think actually whilst a faster time to test result would be really good, and we're always keen to look for alternatives, I guess, as new technologies become available in the pipeline. The main things are around staff capacity and having the time to do the test not so much the runtime, but just thinking, you know, if they do that, they can't do something else. So it's a kind of a trade-off. So there's, in part, yes, a faster, simpler to use test might be encouraging, but actually I think the sustainable workforce in being able to offer compensation, that's quite a driver, but also broadening the operator workforce to potentially people who might not leave community as frequently, and also giving a bit more responsibility to certain staff in the health service who then might have an interest and potentially a career path to not just do STI point of testing, but take responsibility for all testing. And that sort of opens up then potentially a whole nother suite of strategies and ways to make it work, I guess. There's a little bit of other, you know, maintenance and the QC and the EQA. I mean, there's always that in the background that I guess kind of is a bit of a detraction. But if people are well trained and understand, I guess it's about understanding and embracing the benefits. And if once you do that and you can see that it's saving you time or it's helping prevent sequelae or it's improving the outcomes of a pregnant woman, that's pretty strong. But some of that it's difficult to keep, and difficult to keep STIs as the priority when you've got other priority things going on. Emergencies, air evacuations, you know, is now the time to pop on a point of care test for an asymptomatic screen. Yeah, so.
I think you started to talk a little bit at the end about what I was going to ask about, but I mean, first of all, congratulations to Louise and all the team. It's amazing. But you spoke at the beginning about how, you know, part of the rationale for introducing the molecular point of care tests were that, you know, people in remote communities were at a real disadvantage in terms of, you know, access to lab results. But I think it's quite striking that, you know, with these machines, people are arguably getting a better service even than people who might be in a city and you know, quite near a lab, but who may not get the result until the next day or something. So you mentioned that there are new uses for the machines that are being planned, and you started to talk about that. But I wondered if you could just reflect on the ways in which the services might have been able to leverage that advantage that they potentially bring.
With the other assays, or do you mean
just getting a result in an hour? Like, do people wait, or do they?
Yeah. So I guess it's a bit mixed. It's very health service dependent. And I guess, you know, they've integrated it in a way that makes it work for them. I mean, there are certainly examples of where people are coming into community and being sort of in the hub of the community, perhaps going to the grocery store and things where actually, you know, 3 or 4 hours isn't, they're just down the road. They're in town for, you know, the day or for several hours. So whether it's a 30-minute or a 90-minute test might not make a difference. However, if you imagine in some of those community screens where they're trying to get through a lot of tests in a relatively defined period of time, that does require some special thinking. You know, we do provide the option of having additional equipment. So for that period of time, if you need a second device, you've got 8 modules. That means you can, you know, you can basically set up sort of a mini lab whilst paying attention to quality and preventing, you know, all the other things, kind of right specimen, right result, all those sorts of things, which is a whole nother discussion. But in those settings, you know, you actually need, the limitation is the staff. You need one person dedicated to be able to do that for the entire workday when you need to be seeing people who are doing other things. So it's a little bit of a mix. Some people in some settings where they've collected specimens from community, brought them back, you know, then they set aside a few hours and then it's just this turnover, but they can call the result to the person who's out in the field, and it's almost like, say, you know, real time, even though it's not happening co-located.
Thank you.
Okay, so if there's no more questions, just like to again thank Louise for a really terrific presentation, which I think is true memorial to Brett's approach to working, so, and is centered on equity. So thank you, Louise, for just a fantastic presentation.